computer. Right, okay. So it's recorded, so people who can't get hold of us today will be able to get the Q&A session on a recorded version, which again will make available, and you get contact Liv to do that, and she's on your group. Right, I'm just going to get the questions up, which are here somewhere, all computerized. Right, just a second. I knew that was what's going to happen. Just be a second. While still anybody else joining? No. It was all working perfectly before. I've got an iPad here with the questions on that. Okay, so welcome and thanks to all the people that set this wonderful Facebook page up. I've heard about it over the years, and I think it was Tom that started the whole thing off, so well done, Tom. I'm going to go through the questions that have been sent in first, and if we have time, hopefully there will be, you can sort of ask more questions if you go through. I'm just admitting everybody. There's a few more people joined in. So I will hopefully try and answer all the questions that you have, and we'll move on to other questions at the end of this first part. So we'll start off with Karen. I'm going to mention the names of the people. Karen Everett. I don't know if Karen's here on the, yes, she is connecting to audio. Hello, Karen. Okay, so the question was, my daughter, aged 15, has very recently had a return to good health. Right, just a second. There's just a sec. So there's people still trying to get in here. My daughter has very recently had a return to good health after a relapse of Lyme disease. She's seeing her Perrin technique practitioner every 2 weeks and on a herb supplement and diet protocol. My question is, should she have the flu vaccine, the nasal spray that they have decided to give to all secondary school children, and or the COVID vaccine? I'm reluctant to risk her recent good health. She has had one healthy year out of the past 4 years. Every good day is very precious. Well, this is a really very interesting question and very vital question at the moment. And I get this question asked all the time about the COVID vaccine. And I researched into talk about the COVID vaccine first. When the Pfizer and AstraZeneca came out, I got in touch with AstraZeneca and Pfizer, and I spoke to the head of communications from the official heads of both firms to find out exactly what they were telling the pharmaceutical industries, and what they were telling the medical profession about their vaccines, how safe they were, and in view that many patients with ME get worse after having some vaccines, which one would be the safest. And after looking at all the ingredients, I worked out that the safest one to have was the Pfizer. And the reason for that was because the Pfizer is frozen to a very low degree, and it has very much less additives and adjuvants, which are things that push the vaccine along, which promote the vaccine's effect. And the preservatives were very minimal because it was deep frozen. So the AZ, the AstraZeneca one, and the Moderna one are not in the same safety spectrum as the Pfizer, but that doesn't mean they're safe. And you can have a vaccine and get much worse. Flu vaccines, I tend to have tell patients to try and avoid as much as they can, unless they're very vulnerable. So Vaccines have a risk. And a year ago, in the International Association of ME conference, I asked this question before any vaccine came out. I asked their heads, some of the really top specialists in the field of ME, including there was Lewis McCall from the UK. There was a few professors from different parts of the state. Lenny Jason, some of you might know these people, and they refused to answer the question. In fact, nobody answered the question. Everybody kept completely stum when I asked what vaccine, or do we actually offer a vaccine to patients in view of the fact that vaccines have been shown to trigger the beginning of ME in some patients. And it's in the international consensus criteria that vaccines can lead to it can be a trigger for ME. So years ago, vaccines were pretty nasty stuff with what they had in. Nowadays, they're trying to get better with the additives. But years ago, it used to contain, most of them used to preserve with thimerosal, which was a terrible mercury-based preservative. Now, thimerosal is not used now as a preservative. They've realized injecting people with mercury isn't a very good idea, even if you haven't got ME. So then they started looking at what else they're putting in. And then as my new book talks about this in detail, they started using aluminium oxide as an adjuvant, as something to speed up the process. And again, it's not heavy metal, but it's still a metal toxin, neurotoxin. So I advise people to avoid vaccines as much as they can. Nowadays, they make most of the flu vaccines without any of these nasties, but they still have alcohol in, so ethanol, and this is where AstraZeneca and Pfizer differ, with Pfizer being frozen as little or no ethanol in at all, and the AstraZeneca does. So you don't really want to inject ethanol into a person with ME. And the reason for that is because it affects the brain, not just the liver. The small amount of ethanol is not going to do much damage to the liver, and you need the liver to work well. It's more the brain, and you've got the basal ganglia in the brain, and you've got the NMDA receptors in the brain, and these are two major receptors that get affected when the drainage, when the neurolymphatic system doesn't work properly. So vaccines have a risk, but you've got to weigh up, and this is it. Do you want to get the illness? Flus lead to ME, viruses lead to ME, and viruses often make the ME patient worse. You'll find, and I say this in my book, in my earlier book, and my new one, I mentioned about viruses, and that flus and colds, a lot of patients don't seem to get. Once they get ME, they don't seem to get, because their immune system's upregulated to begin with, and they just feel ill all the time because it's overworking. As far as your daughter's concerned, should she have the flu vaccine? I would say probably is best to steer clear of that at the age of 15. There's no likelihood of her getting really seriously ill with flu, although the problem of the vaccine might trigger a worsening of her ME. The COVID vaccine is a bit different. We don't want anybody to get COVID. But if you boost the immune system naturally, then it's helping, but it's a personal choice. Now, obviously, since your daughter's 15, it's your choice to make as a mother. Above anything below 16, and it's the parental choice. So it's up to you. It's a very hard one, and I'm sorry, but I have to take the fifth on that and just say it's really, you have to weigh up whether you should have it or not. So it's something we can't tell people they definitely should have. If you have major sensitivity problems, or if your daughter has things like mast cell activation syndrome, If she has things that are a lot of ME patients are very sensitive to chemicals, have a lot of chemosensitivities and mast cell problems. That's they get allergic or allergic reactions to lots of things. If that's the case, then even AstraZeneca and Pfizer advise against taking the vaccine. And this is one thing I got from them. They said they've not done any tests on people who are severely allergic or severely have severe reactions to these chemicals, and therefore they advise against taking the vaccine. Okay, right. I hope that answered it to the best of their ability. Rosemary Bland.
Ray, would you want to make me co-host and I can just keep letting people in while you're going through?
Yeah, absolutely. Sorry, there's people who want to get in there. Co-host. How to make you co-host? Make host. Okay, right. Yeah. Do you want to change? If I make you the host, will I be able to carry on?
Yeah.
I think so. Yeah, I think right. Sorry.
Great.
You're the. I'm not. I'm right. Right. Okay. Sorry about that, folks. Right. Second question. Rosemary Bland. Is Rosemary here on the? Rosemary. There's Rosemary there. I think Rosemary Bland is there. Yeah. I've had over 2 years of Perrin treatment, but the osteopath says my mid-back is stiff and often not able to be manipulated, impairing drainage and delaying healing. Rheumatologist says it's fibromyalgia causing stiffness. Do you have any suggestions on how to break out of what seems to be a vicious cycle? Thank you so much for the session and sincerely wishing you the best. Right, Rosemary, basically, fibromyalgia and ME, if you read my new book, you'll see that they have the same pathophysiology, the same things that cause ME can cause fibromyalgia. If you have been diagnosed fibromyalgia, make sure it is fibromyalgia and it's not just ME with pain. In my book, I describe how to tell the differences, but whatever, it shouldn't affect, it depends how old you are, and it depends how much stiffness there is. If the back is stiff, then you can do the turning exercise, rotation exercises, you know, the ones in my book, the turning ones, and do them regularly. Remember sitting down when you do the rotation ones, and then you stand up and you do the shrug rotation of the shoulders forwards and backwards. So those are standard exercises you should be doing 3 times a day at least. Now, if your spine's stiffer than it should be, even with the treatment, you should do it more than 3 times a day. If you can do any activity at all, swimming, that's why we say sculling swimming is really good for the spine. But you need to keep it as loose as possible with exercise, just gentle exercise, and that will help. So you should put cold on your spine with fibromyalgia and warm on the muscles, and that will relax the muscles and reduce the tenderness and inflammation in the spine, and that should also help. But after a while, you should be able to get the spine moving, and if the osteopath is not able to manipulate it because it's so stiff, then you need to do more exercise and stretching, and the osteopath can work on that. So it shouldn't be a problem if you can get that moving. You don't have to be manipulated, just stretch, but gentle stretching from the osteopathic point of view. Amanda Ross, how important is posture for CFS recovery? Is Amanda here? I'm not sure if Amanda is here, but anyway, if you are, welcome. How important is posture for CFS recovery, both during the day and sleeping posture? Do you have any advice on this? Well, it's in my book, a lot about posture. In fact, all my work is about posture, really. How important? It's incredibly important. And I'm not the only one that says this. Some of you might know the work of Professor Peter Rowe in Johns Hopkins University, who's been examining the posture of ME patients as long as I have. And we work very similar. He has a team of practitioners using osteopathic techniques to help. But he's noticed the same thing as I have, that the mid-thoracic area, the mid part of the spine, is usually very stiff, and posture is everything to do with the problem. And why? Well, if the posture is wrong, then your nerves that come out from your spine can be affected, but more important, the blood vessels supplying those nerves that come out from the spine are affected. And around those blood vessels are what we call the perivascular spaces, the spaces that we now know contain this neurolymphatic pathway. So it will affect the drainage down the spine. It's not just the brain, it's the spinal cord that drains off toxins as well, and posture will affect that. So yeah, does sleep affect it? Yeah, absolutely. Sleeping posture is so important. And again, in book 2, I described exactly what has been shown scientifically to be the case, and what we now know without doubt is lying on your side is a better decision. Left or right, doesn't matter. Left is meant to be better for your cardiovascular system. Left is meant to be better for if you have gastric reflux, you should lie on your left side. But either side will allow better drainage of the spinal cord. So yeah, posture is so important. You should lie on your side, put a cushion between your knees to keep yourself in one position, and make sure your head is not tilted one way or the other. So enough pillow to keep your head completely horizontal to the mattress. Okay. You say in their patient handbook that it's common for patients to feel worse at the start of treatment, and that is often a sign of treatment will help them. In roughly what percentage of patients is this the case? Is there a risk of side effects being longer term, or do they subside if and when the treatment is stopped? Right. This is very much a question that practitioners need to know about, and there are some practitioners on this Zoom meeting. But this is something I stress again and again when I give workshops and I teach practitioners. It's very much patient-led, the treatment. You have to use your practitioner knowledge, practitioner intuition as well, to work out if the treatment that you gave should have elicited certain results. And the more forceful the treatment, often eliciting a more forceful response. But you want to go cautious to begin with. You don't want to try and get all the toxins out right at the beginning. I mean, we're talking about sometimes thousands upon thousands of different toxins. And if you drain them all away very quickly, your person's results could be really seriously ill. So you don't want to go gung-ho. But if you do a minimal treatment and the person still has a major reaction, it shows how much toxicity is in there and how important the treatment is. But then you don't need to go gung-ho then. You have to go very, very gradual, very, very, very gently. It's a very softly approach. Now, if the patient is continuing having side effects and they're getting worse and worse and worse, and the treatment doesn't seem to plateau out the symptoms and they're just going downhill, you have to think of what's going on here. Is the practitioner doing it too forcefully? Possibly. Is the patient doing too forceful self-massage or doing the exercises all wrong? And we're going to go through that and make sure you do it right. But there's lots of reasons why a person goes down and down and down, doesn't pick up, and you have to find out the reason. It shouldn't be the treatment. The treatment should, to begin with, maybe start, and maybe there's this really sharp decline in the symptoms for the first few weeks because there's a lot of toxins coming out. If the person can cope with it, fantastic. Then you usually start seeing an improvement after a while. And that's when I talk about the worse symptoms, then the beginning, the better. But if the person is continuing to steadily decline, that's not good. There's a reason for that. There's either doing the wrong treatment, the wrong type of treatment, or they need other things as well. But it's usually, what I've found in most cases, is the practitioner going a bit gung-ho, or the patient themselves doing the wrong things and going too forceful and doing too much. I also, I say to some severe patients, well, you're doing the self-massage at night time, aren't you? The full routine just before you go to bed. And they're saying, oh, we're doing it 5 times a day, because you said you can do it 3 times a day or more if you really want to. And that's not what I say. I never say that. And in my book, my new book, I quantify exactly how you should do it. But basically, a severe patient should only do once a day. Most patients, and that's the standard, the full drainage, the head, the face, the neck, the chest and the back. That drainage, self-massage, should be done at night time. We now know it's best at night because that's when naturally the drainage in the brain occurs. And then they don't do any more than that self-massage. Now, if patient isn't that bad, and on our scale of 0 to 10, where 0 is dead and 10 is perfectly healthy, when they're around a 6 out of 10, I will say, you know, you can do a bit more. Or if they come in and they're not too severe in the beginning and they're 6 out of 10s, and that's quite good, I say they can do more, and you can do a self-massage routine on just the head and neck, not the full routine. A few times a day they can do the head and neck, but generally the golden rule is just you know, less is more. I always say less is more, and just doing the full routine at night time, if you can, before you go to bed, that's the best. But percentage wise of how many patients get much worse before they get better, I would say maybe about 10% of patients get much worse before they get better. A lot of patients feel bad for maybe a day or two. Most patients generally feel worse. I would say about 90% of patients, when they start the treatment, feel worse. They're the ones who hopefully will recover, but around 10% feel really bad. And then you've just got to make sure you're not overdoing it. Okay? And sometimes we change the treatment because of that. We reduce the time of treatment. Since developing CFS, I've had enlarged lymph. This is still Amanda Ross has got some nice questions. Since developing CFS, I have had enlarged lymph node behind my right ear. What would you expect the treatment to remedy? Well, if you've got it around the right ear, then you just have to do more drainage below the lymph node, so and down the neck to the front there, like I'm doing now. Do more of that. You can do it during the day as well. Just drain below the lymph node. Don't touch the lymph node at all, just below, and that will hopefully help to round things off, to make sure you're not having too much drainage. You can do the other side as well. Okay, so just do a bit more of that, maybe together a few times a day. Okay, but don't do it too forcefully, very gently, and that should help. If someone is improving on their own, would you still recommend they try the Perrin technique? Well, if they're improving, fantastic, excellent, and they're getting better, fantastic. But would I recommend the technique? Yes. If they've got ME or fibromyalgia, definitely, because my whole work has been to try and prove that the drainage system of the brain is affecting patients with ME. And now, the new book, my book 2, has got a lot of science behind it to back up what I've been saying. And I've been working for quite a few years with different doctors, and one of the doctors I work with in London, a neurologist, Dr Ray Perrin, I worked in her clinic in Harley Street for a couple of years. She used to say to me, Raymond, you're not treating the pathology, you're treating the physiology. So you're not treating the disease process, you're getting the body to work better, which is what osteopathy is all about. We're trying to get the body to work much better. And it doesn't matter about the illness itself, we're treating the body. So by stimulating the drainage, you are helping remove the toxins, you are helping remove the inflammation, mostly caused by what's known as cytokines, which are pro-inflammatory toxins that come about from they come about from infection. Often it can be from other causes, but infections lead to cytokine involvement, and you need to drain those cytokines away. And if your neurolymphatic system isn't working, that's the key common finding that I found with patients with ME, is their lymphatic system is working the wrong way, and you need to get it working the right way, the right direction. So yes, Perrin technique should help patients even if they are improving, and it should speed up the whole process. Yeah. I have recently experienced significant weight loss after a setback. Although my appetite has now improved, I am finding it difficult to get enough calories to get back to healthy weight. Do you have any advice on this? Well, this is all about leptin. Leptin is a female, more male hormone. It does occur in male, but much more in females. It's a cytokine. It's also known as an adipokine. It's a hormone that is attaches to fatty cells and is a signaling molecule that is very important in satiety and hunger, in control of appetite and loss of appetite. And what the workers, researchers in Stanford University found out quite a few years ago, that leptin is involved. And Jared Younger, who's now, somebody else mentioned Professor Jared Younger, we're going to talk about his work later, but he's a neuroscientist who's worked now in Alabama University. He was going to be the keynote speaker for my conference this year for my practitioners, but unfortunately he's on sabbatical. But he knows about my work with Meta a few times, and he recently emailed me and told me he's really excited about what's going on with the Perrin technique and congratulates me on getting much more talk about my work. So he's seen it out there. He showed there were a whole group of cytokines stuck in the brain with ME, and when he was working in Stanford. And now Stanford have shown at least 17 cytokines in the brain of ME patients stuck there because they're not draining away. And one of them, and the main one, is leptin. And as the leptin went up in value, so did the ME symptoms, and vice versa. So we had a problem with leptin, and that's why a lot of patients with ME put on weight or lose weight or find their appetite going. They have a hunger. Ravishing hunger, or they get addicted to certain foods. They become chocoholics, some of them, but some of them opposite. They just can't eat anything, and they find it very difficult. So this is something that does happen, and the weight loss could be very much to do with that, or it could be to do with the thyroid or the adrenal glands, which are connected to the hypothalamus in the brain, which is the main organ of the brain that's going wrong with ME. And that is the mother of all hormonal systems. And basically, if your hypothalamus goes wrong, then your adrenals could go wrong and your thyroid can go wrong. That can cause weight loss. So I would have a check of your thyroid and adrenals, but it's probably the leptin. And it's the best thing to do for, and I say this again and again, for food-wise, the standard, I mean, there are different diets that are good for one patient and bad for other, but if you have small regular meals and don't have too much at one time and have lots of different variety, reducing milk, reducing gluten, reducing sugars, yeasts, and that will help. It should help in most cases. Okay. And I say maybe 6 meals a day. And how we do that is break up the breakfast, break up lunch, and break up dinner into 2 separate parts each time. So you divide the 3 meals a day into 6 meals. Right. Okay, we have a question from Andy Micklethwaite. I had a diagnosis of ME, but not classic, about 25 years ago. I've had recent, I love that, ME, but not classic. ME is never classic. I mean, every single person with ME is different. There's not one ME patient the same. So it's very interesting to know what classic ME is. Anyway, but about 25 years ago, I've recently had more than 6 months of sessions with a Perrin technique practitioner and feel neither better nor worse. Yet if I go to a moderate altitude, say 600 plus meters, alpine resorts, e.g., I feel much less fatigued, often within a couple of hours. And if I use the transport systems there to get even higher, there's even much more benefit. Can you offer explanations? Well, it's very simple. And this is actually, some famous doctor years ago said, best thing is to go into the mountains, go to the Himalayas or somewhere like that. If you go into an area where there's less pollution, and the higher you go, there's less pollution, the more fresh air you get, the better you'll be. There's no question about it. The trouble is, if you go higher altitude, there's less oxygen. Now, less oxygen might be something that could be affecting you. It might be you have breathing problems and possibly there's hyperventilation going on, and that hyperventilation could be causing the fatigue. So I'd check out your breathing first of all, and also it could be that you're suffering from a lot of pollution, and when you go to an area where there's less pollution, you feel better. So that could be the explanation now. If you had treatment for 6 months and feel better, no worse, I'd start thinking there's other things going on, and this could be a solution to some of the things. But I'd definitely look into what else is going on. It's not just ME. Maybe that's what you mean by not classic. Okay. So early. If there is time to cover it, I have some questions for Dr. Perrin as a moderator. Sarah, you're there, obviously, as a moderator. You're there. I can see Sarah. Is that you there? You can unmute if it is you.
Hello.
Yes.
Yes.
Hello, Sarah. So you're the moderator for this bunch.
I'm a moderator, but Tom's the one you've got to thank.
Is Tom here?
No, I've been looking, but he doesn't seem to be.
Oh, he's avoiding me. I have spoken to him in the past. But yeah, anyway, Sarah, thank you very much. Yeah, I've got time for all the questions. I said we'll do this for an hour, but I said to Liv at the beginning, I was going to have a Zoom consultation with a patient that's been postponed because I do for at the moment with COVID for patients who are abroad. I can't get to them at the moment, although I am starting to travel next month again into Europe. But for my international patients, I'm doing Zoom consultations and trying to get practitioners involved. I've got somebody next week in Brazil, in Rio de Janeiro, who's being treated by an osteopath in Rio, and we do Zoom. So I was going to have a Zoom consultation with this patient this afternoon, but it's been postponed. So I have got more time. So we will be able to cover all the questions and a bit more. I'll stay on till 5 o'clock today. So we've got 2 hours rather than 1 if any of you want to stay on. So anyway, going back to your question, Sarah. Right, can you say anything about POTS and whether Perrin can help POTS? Yes, we'll talk about it in a minute. The next one is about high-dose thiamine and oxygen treatments. Any vitamins and oxygen is useful. So we're going to just a second. Something coming through. Sorry about this. No, I'm sorry. I thought somebody important, but I don't think it is. Yeah. Sorry about that. Right. So the next question is, right, I'm just seeing it all, it's all separate, right? Okay, so we'll start at the beginning. Can you say anything about POTS? POTS, postural orthostatic tachycardia syndrome. In my new book, I have a whole section on POTS. So a lot of you are asking questions that are all answered in my new book, the Perrin Technique, second edition. So if you want to go into the details of everything, that's the book for you. So just briefly, yes, POTS and ME and fibromyalgia, and also there's Ehlers-Danlos syndrome. There's also mast cell activation syndrome. There's a whole group of different problems that are related to ME, which I talk in detail in my new book. POTS is an extension of what we have with most ME patients, which is postural disturbances that affect the blood pressure. So you get postural neuromediated hypertension, and the blood pressure drops, and you get vestibular problems, and you get heart rate can go up, the tachycardia can go up. And this, if it gets to a point where you have a certain amount over 30 beats after a certain amount of time, it's classified as POTS, and that's called postural orthostatic tachycardia syndrome. This is heavily dealt with by Peter Rowe. I've mentioned him already, in Johns Hopkins University, and other doctors in the world are looking into POTS big time. So POTS is a major factor in some ME patients. There are genetic predispositions for POTS and ME together, so it's important, if you have it in the family, it's important to have your genetic testing done to see if you have this gene problem, and that can sometimes be helped by certain medicines. Now, there is a genetic disturbance of, you talk about thiamine later on in the question, which is vitamin B1, but this vitamin B9, which is folic acid, and that, if you have a folic acid problem, you have a folate problem, that could be a genetic, and that can lead to a lot of different disturbances, including ME, fibromyalgia, POTS, and Ehlers-Danlos syndrome, and this can run in families. So it's important to have this HTMFR test, it's known as, and I talk about this in my book. So all that side of things, I think you need to get the Perrin technique second edition with all the information about that. Thiamine is vitamin B1. I go on to vitamin B complex as a big thing. We need the vitamin Bs, and every patient of mine gets supplemented with vitamin B complex. It's not just the B1 or the B9, as I mentioned, the B6, the B12 is so important. So the vitamin Bs help the nervous system work better, help the energy in the body, help with the methylation cycle, which is important precursor for what's known as the Krebs cycle, which is what changes ATP to ADP and it reduces energy in your mitochondria, very important for ME. So vitamin B, very important, and so therefore the thiamine is very important. Oxygen treatments, yes. Now a lot of people tell me about they go to a hyperbaric chambers to have the oxygen. You don't go to hyperbaric chambers. It can help some patients, but it can make some patients much, much worse. And that's because it's the pressure. Oxygen is brilliant. We need, the whole argument about mitochondria. I know most of you might know Sarah Mahill's work, and there's a lot of talk about mitochondria. As Sarah puts it, it's not hypochondria, it's mitochondria. Basically, mitochondria are the organs in the cells that are involved in energy production. And what we've found is that most ME patients have a mitochondrial problem. Why? Now, I don't believe in most of the scientific argument that it's because the mitochondria stop working and we need to get them working again. I think they would be working if they got the right supplies. You need the right nutrients into the mitochondria for them to work. So what's the raw materials for any energy production? You have two major raw materials, oxygen and glucose. So you need oxygen and glucose to produce energy. If you don't have a good cardiovascular respiratory system, if your lungs and your heart isn't working as well as it should do, and you're not getting the amount of oxygen into the blood to get to the cells, to get to the mitochondria, then you are going to have a problem. Likewise, if your gut isn't working properly and you're not absorbing the glucose needed to fuel the fire in the mitochondria, you're not going to get the right amount of energy. So you need oxygen, you need glucose, and you need a good cardiovascular system, respiratory system. You need a good gastrointestinal system. And ME patients have neither of that. The cardiovascular respiratory system isn't working because that's controlled by sympathetic nerves, by the hypothalamus and other parts of the brain, and all the brainstem. And also you have the gastrointestinal problems. You have leaky gut, you have gut dysbiosis, you have problems in the lymphatic drainage in the body, in the gut, and therefore you're not getting the right amount of glucose absorption, and therefore you're not getting the raw materials from either oxygen and glucose, and therefore you're getting mitochondrial problems. So you need to get the sympathetic nervous system working better, you need to get the drainage working, you need to get the blood circulation getting better, you need to get the oxygen supply, you need to have the bowels working better, and that's what this treatment will eventually do. What do you think about patients who continue to explore other options and treatments alongside Perrin's? Absolutely, and that's, again, book 2 has loads of different advice about other different types of treatments. I've never said the Perrin technique is the cure-all, never. And I want this to go out. You can spread the word. I am saying now, the Perrin technique is part of the picture. We'll talk in my new book, and especially in the Perrin's, some of you might not know about the new book, hopefully most of you do. I've got copies of it somewhere. I'll just briefly go to my library and get my copies. Give me a second. Okay, sorry folks. Right, I'm back. So this is the full Perrin technique, the new second edition. And it says it quite clearly, how to diagnose and treat chronic fatigue syndrome, ME, and fibromyalgia via the lymphatic drainage of the brain. A great apologist to the people at that. In the book, I say ME CFS, and I know a lot of patients don't like the term CFS at all, and they like ME CFS, the ME first. In the whole book, it's got ME CFS first. It's just, it didn't look good on the cover. On the cover, it didn't fit in well, so we called it chronic fatigue syndrome, stroke ME, and fibromyalgia. But the rest of the book all has ME CFS all the way through. Anyway, but in this book, it's got everything that you need to know. So other treatments, there's a whole section on other in the book. I mean, chapter 1 is the basics. Chapter 2 is what it is. And then chapter 3, the role of the sympathetic nervous system disease. Chapter 4, the causes of ME, all different types of causes can trigger. And then treatments, chapter 5, treatments for ME, CFS, and FMS, fibromyalgia syndrome, other than the Perrin technique. And it's from pages 101 all the way through to 156 is chapter 5. There's so many different types of treatments that I advise people to look at, as well as my own. So what's it all about? So basically, in a nutshell, the Perrin technique is part of the picture. And I now use an analogy that I've taught to my practitioners to use, and I call it the jigsaw puzzle analogy. When you're treating ME, when you're diagnosing and treating, look at the patient like a jigsaw puzzle. And we've all made jigsaw puzzles. And if you're good at making jigsaw puzzles, you'll know that the best way of starting a jigsaw puzzle is the corners first, then the edge pieces, and then the center, then the middle, the sea and the sky, whatever. Now, some jigsaw puzzles are very simple. Some are very straightforward. That children's jigsaws might be just 6 pieces and just made of corners and edges. Those are the easy patients to sort out. Then there's more complex patients, and there's even more complex. So what are the corners, and what are the edges, and what are the middle? So in the treatment, the corners, and this is so important, remember this, if you don't do this, you won't get fully better. You need these corners on the road, and this is all ME patients, regardless of what avenue you choose for afterwards. First of all, rest. You need to learn how to rest. And rest means resting, not sitting down and worrying about everything. So you need to relax as well. That's the second corner. The second corner, relaxation, is so important. You need to know how to rest, sitting or lying, and don't sit in a soft chair slouching all the time. That's not resting, because you're putting strain on your spine. You need to rest in a comfortable, healthy posture, lying down on your side with a cushion between your knees at some time during the day even, and the settee. That might be a good way of resting. Relaxing is so important, but some people cannot relax. Most ME patients are type A personalities, so you can't relax, you can't unwind, you're all stressed all the time. And the more you rest, the more you feel more stressed and the less relaxed you get. And if you've got something to do important, if you've got work to carry on, you're not going to rest and relax. So if you can't relax, learn how to meditate. It's so important. Meditation is everything. If you can't relax, then mindfulness, thinking about the now, thinking of the present, that's so important. And that's the third corner. And the fourth corner is the most important. And it's something I started in 1989, when everybody in the world of ME was saying, push, push, push. When I started with treating ME patients in the late 80s and early 90s, all the doctors were saying, you know, that's when they called it yuppie flu. You've got to get out and do more. You're not fit enough. You're in office all day long. You need to go out and play more sports. And their patients used to crash. And I was a lone gunman at the time, always the minority of one. You know, for years I've been on about the neurolymphatics, and now they've discovered it. So, and years and years and years I was going on, we need to pace. Patients mustn't push. They need to pace. graded exercise therapy doesn't work with ME. It's not a treatment for ME. It's a treatment after the patient is better. Then this can start increasing their activity bit by bit, and that helps recondition a deconditioned body if we've had lots of years of rest. But patients with ME are not going to get better, as you know, from pushing themselves, and the graded exercise therapy argument still firing on all 4 cylinders in the NICE guidance, which hopefully come out soon, without the dreaded get in it. But the pacing is so important. And when I first was talking about pacing at conferences years ago, one doctor said, "Do you mean pacing up and down a corridor, you know, as fast as you can?" I said, "No, it's not exactly what we mean by pacing." And my golden rule, and most of the patients of Perrin technique practitioners will have heard this, is the half rule. So I started this years ago in 1989. I started the revolution of pacing, and it's caught on. Thankfully, now most of the world are saying to patients, you need to pace. And that's the 4th corner. Pacing half of what you feel capable of doing. Now, a lot of patients say to me, how do you gauge that? It's very difficult. Well, you have to think double. And I talk about this in my book. I say, think if you're walking 100 meters, think double. Can you walk 200 meters? Yes? Then 100 meters are okay. If 200 meters is definitely too far, then you're doing too much at 100 meters. But can you walk 100 meters? Probably. Then you can walk 50 meters. So always think hard. And that's not just in activity, it's everything. So if you're listening, if you're watching television, if you're talking on the phone, or if you're doing any mental work, everything has to be done half of what you feel capable of doing. And you always must say, can I do double this safely? And the answer has to be unequivocally yes. So that's important. And this is the main 4 cornerstones. So it's rest, relaxation, meditation, and pacing. And the edge pieces are the Perrin technique. Is getting the mechanics, the fluids in the body, getting the drainage of the lymphatics working better in the brain, in the spinal cord, and getting the mechanics of the spine and the cranial flow working better. And that is the key to improving the person. Now, it depends how big a jigsaw puzzle you are. Some patients are 100-piece jigsaws, some people are 1,000, because then it's the other things that are needed. If somebody has a lot of other conditions, they might need, for POTS, they might need to do certain activities that POTS do. There are certain exercises for the legs that they might do to strengthen the control of blood flow from the legs. They might need to wear supportive stockings. They might need to take extra diet of salt and more fluid. Everybody has different requirements. Every ME patient's different. So some patients are very complex and need a lot of different, have other things, other issues. It's ME plus, I call it. And those patients may be 1,000-piece jigsaw. I have one patient who's so complex, she says, I'm the baked bean jigsaw puzzle. If you know the baked bean jigsaw puzzle, it's one of the most difficult. It's just beans, lots of them. And she says she's the baked bean jigsaw puzzle of health. But if you get the cornerstones right, you get the Perrin technique sorted, then it'll be easier to fill in the sea in the sky, fill in the extra things. So that's why other treatments are crucial in many cases. What do you feel is the minimum someone needs to follow in terms of self-massage routine? This is still Sarah's question, another question, routine, supplement to feel benefit, and is there one aspect that's more crucial than the other, e.g. the supplement, hot, cold, nasal release, full chest or back massage? Right. One of the golden rules is to get the spine working better. So of the self-massage, self-exercise routine, the one thing that needs to be done and needs to be done for life is the turning exercise. So we're going to run through it because most patients get it wrong, and most practitioners, unfortunately, even though I teach it and I tell them, and it's in the book, they still teach the patient wrong, or the patients get the wrong end of the stick. So I'm going to show you exactly how it should be done. You need that spine to move better. And that is a key area to the whole thing, because once the drainage works better in the spine, it's going to help generally. So as long as there's no pain at all when you do it, if there is pain, you just do it less. And you do a max, hands over there, so you can all do this whilst I'm doing it together with you. Just turn each way gently, and that's as far as you go. So a movement of around maximum 60 degrees. It can be a bit smaller, 45 degrees. That's the whole arc. So you don't go 60 degrees one way, 60 degrees the other way, which is 120 degrees, which is quite a lot. You do the whole thing, maximum. So that much movement. And you start by hands to the side of your neck, not clasped behind, not up on your head, to the side. Okay, so hopefully you can all see this. Liv, can you see this?
Yeah, that's good, Ray.
Right, okay. Then hug your shoulders. And hugging shoulders can be done this way or hugging like so. Okay, Julia, can you switch off your thing? Sorry, lovely seeing you, Julia, but we don't want anybody's camera on because then it affects the signal I'm getting. So can you just take your camera off? Is it possible? If too many cameras come on all together, we're going to have problems. Yeah, thank you. Later on, when we ask questions one by one, you can open up and show me what you're doing. Okay, right. So hands to the side, hugging shoulders, folding arms. Next one, I just lower this down a bit so you can see. And I'm folding my arms and doing the same thing again. Just a little gentle movement. And that's all done sitting down. So many patients of mine come and say, I'll show them, and they'll do it standing up, or they're swinging their arms around and doing all sorts of things. It's just very gentle. And it's in the book. It's in the first book and in my new book and in the patient handbook. Okay, then the next part, if you can stand up, because if you're wheelchair bound or you find it very difficult standing up, or you've got POTS, sit down, do it sitting down. But if you can stand up, you stand up. And you basically, so you stand up now, you do not do that or anything else, you do rotation. So I'll show you, I'm rotating my shoulder around. So it's not just shrugging up and down, it's not big movements, it's just gentle movements, gently 5 times one way and 5 times the other one. And that's the rotation movement. And those should be done 3 times a day, not once a day. They're simple to do, they take about a minute to do it. 3 times a day, should be doing those for life. It's, it gets a bit of a pain, but once you get used to it, it's part of life. So do it before breakfast, lunch, and dinner if you have 3 meals a day, which you should do at least. And if you want to do it more, fine, but minimum 3 times a day. And that's so important. I would say that is the most important part. Cutting the inflammation down is also important. So hot and cold to begin with. Now, sometimes the contrast bathing, the cold and warm, is not going to help. And sometimes they need cold only. So cold only. If you have fibromyalgia, if you have severe widespread pain and it's fibromyalgia, then please, excuse me a second, do cold only on the spine and warm on the muscles. And again, I mentioned this in my new book. The full chest massage is important, but if you can't do it, then the treatment alone should be enough if you have a good treatment once a week. The massage routines, if it's too much for you, leave it out, but they do speed up the process. Okay, and the nasal release is all part of that process. If you do the nasal release and you don't do the rest of the massage, it's not worth probably even doing the nasal release. You should do the face, neck, but don't do the face, neck, shoulder, back 3 times a day if you're very severe, and you shouldn't be doing it anyway 3 times a day. You do it once at night before you go to bed. The three times a day or more is just the face, the neck, and the head, just as a top up, but not the full routine. It can be overloading the patient and can make the patient much worse. Too much toxins out too quickly, not a good idea. It can really knock you for 6. If you got all the toxins out straight away, it could kill you. It really could. So you don't want to drain off too much at times, so gently, softly. How do you know if it's worth persevering with Perrin's? What is their initial improvement and then the plateau decline? Well, if there's plateau and decline, declining means there's other things going wrong that need to be sorted out, and plateau often does mean the same as well. And this is where your clinician should be able to advise you on other things on top of the Perrin's technique. It's not the cure-all for many patients. We did a survey, about 15% of patients get completely better with just our treatment. Now, it might not seem a lot. That means 85% don't, but they get improved. We have 90% of our patients improve within the first year. That's what we're seeing in clinic. But it doesn't mean they're fully better. They need other things as well. The 15% who are fully better is actually way higher than the international average. New report that came in from Norway showed that the average international recovery rate was around fully recovered around 2%, and we're getting around 15% completely better. So we're way ahead of the game in that score. So, but obviously we want better than that. But sometimes with patients, it's not possible. They need other things as well. Okay. So again, it's very much under the clinician, how they feel. If they take a full history and full symptomatology, they should have an idea that there might be something else going on as well. Okay. Catherine Complin. Catherine, are you there anywhere? I don't know if she is, but if you are, welcome. Thank you so much for giving an opportunity to ask questions. There are a few of us that would love you to answer. 1, I have the first book you wrote. Is the new book different, and does it have new, important and extra information? Yes, 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 yes. Now, I'm not saying that because I want you to buy it, but if you're interested in and most of you being on this website are interested, this has all the answers that were posed by the questions that my first book raised. And my first book was based on a hypothesis, was based on my PhD, was based on my theories. We have no evidence to support that. My new book was going to be titled, I Told You So, but that's a bit presumptuous. Anyway, but basically, it is basically saying what all the things I said in the first book have now been shown to be scientifically sound, which is nice. So I can say I told you so, especially to some of my critics in the scientific and medical world. For instance, Charles Shepherd, who always said to me, Raymond, we're not enemies, but I just don't believe in the science. So he had a big question mark over the whole of the neurolymphatic system. And he was right in a way to have this question mark, because according to all the books, there was no neurolymphatic system. There was no lymphatic system of the brain and spinal cord. There was no need for one. I argue differently, saying you do need one. Large molecules get into the brain. We need a drainage system. And it's now been proven. 2017 is proven. So, Charles, if you are listening, which I doubt very much, but if you ever see this recording, hopefully when we meet again, you'll agree that the science was sound. Anyway, Action for ME have just released an article on the Perrin technique in their interaction. And they mentioned this exact point that doctors like Charles Shepherd, who was the ME Association's doctor, if you didn't know, he's been around for so long, most ME patients have heard of him. And they mentioned that he did not agree with my work, but now obviously it's been shown that the neurolymphatic system, or in America they call it a glymphatic system, does exist. So anyway, supplements. This is Catherine's carrying on. On top of the actual Perrin technique, what are the most important supplements do you recommend? Oh, wow. Again, read my book 2. I can go through a whole list of different things, but book 2 has all the different supplements I recommend for different things. I'm not going to say particular doses because everybody's different. But yes, the most important are still vitamin B complex, vitamin C, or for any Americans here, vitamin C, vitamin B. I would say those are most important. Milk thistle extract is important for helping if you're nauseous and helping the detox, helping the liver cope. So that's important. But again, you shouldn't have milk thistle in certain conditions. And so if you're pregnant, you shouldn't have milk thistle. And there's other things that you have to be careful with any supplement. Make sure that you can take these supplements. Make sure your doctor approves of them. But those I would say are the most important. and also the fish oils, if you can take it. The fish oils, or if you're vegetarian or vegan, you can get things like starflower oil, which is very high in omega-3 fatty acids, and omega-6 you have even in primrose oil. So these are important. Fish oils, the omega-3s, omega-6s are important for a healthy brain, healthy nervous system, and helping the immune system work better. When doing the Perrin technique on myself, can I be sure I'm doing it correctly? Yeah, well, in the book it shows pictures, but we are going to introduce a video. We are doing research into long COVID in the NHS. I'm involved with a study with Salford Royal Hospital nearby. And we are doing a study and we're giving out videos to show people what to do. Unfortunately, this is for research and we'll be available in a year's time. Until then, make sure that you're in touch with a practitioner who can guide you through the techniques, and they can show you on Zoom maybe to show you how to do it. Okay. Should the self-massage be done upright or lying down? You should do the first part, the nasal release, the face massage, the side of the head, then the back, and that should be done gently, slow down, rushing it through, but basically a minute, 20 seconds, say, down the face, 20 seconds down the head, 20 seconds down the back. So to start with the nasal release, and you do that 7 minutes for the first 10 days, followed by 1 minute. That should be sitting up, and lying down, then you do the rest of it, the neck, then the chest, then the back, lying down, okay? Oil is essential, or cream, something that's maybe hypoallergenic. We often use almond oil, but it can be coconut oil. Baby oil is not so good to use, by the way. If you only have that, that's okay, but it's petrochemicals in it, so you don't really want to rub too many petrochemicals into your skin. How important is a practitioner experience in the treatment, but traveling times to see her is minimal. Seeing someone local is newly qualified compared to with traveling further. So basically the question is from Catherine is, if you've got a practitioner close by you who's not as experienced as a practitioner further along, which one would you see? Well, it depends on how you travel. If you travel well, then you obviously want to see the most experienced. If you don't travel that well, then go to see somebody. You don't want to ruin the treatment by the traveling distance. So I would say see the close one. If they're licensed Perrin technique practitioners, they have been trained by me, and there are usually physios, osteopaths, chiropractors who have had years of experience usually before they come on my course, but they have been personally trained by me. So, you know, this should all be good. Okay, Kate, is Kate there? That's a long time since I saw Kate. Hopefully she's here. I don't know if she is, Kate. Kate, if you're there, can you unmute yourself, Kate, to say hello? Are you there? Don't know if she is. Oh well. Anyway, she sent in a question. And Kate is a daughter of Ruth Perrin, who was one of our founding trustees of our charity, the For Me charity. So Kate, welcome to this meeting. If not, hopefully you'll see the recording. What is the current situation re the next planned research study? Well, I mentioned it briefly. We are doing a long COVID study. Long COVID seems to be the way forward for research at the moment, and the symptoms we're doing are fatigue related, are ME related, and we're having good results with our patients using Perrin technique. So Salford Royal are sort of sponsoring. That doesn't mean funding, but sponsoring. They're putting a name to it, and that's an big NHS trust hospital in Manchester area. And they're right behind my work all the way. And we're doing a study where it's more going to be self-massage and self-exercise routines based on the Perrin technique that are going to be used. for patients with long COVID and to see if they're going to be helped. So that's the next study, and it should be starting next month. Have you had any further discussions with other ME researchers since participation in Fort Lauderdale at your international conference? Yes, when I was lecturing there, I gave a major presentation there, and I've been in constant contact with people like Peter Rowe, with other scientists around the world. So yes, it's just a matter of getting collaboration. In the recent IFCFS conference, I met up with Mike van Alzaker, who's a neuroscientist and a lecturer at Harvard University, who is thinking the same way as I am about the lymphatic system, the neurolymphatic system, and we're in contact. And hopefully we'll do some collaboration, because they're doing a lot of scanning on the lymphatics and we're going to do the treatment. In the future, we hope to do a collaborative study between University of Manchester, which I'm attached to, and University at Harvard. And if we can put these our minds together, we can create a project possibly of before and after, and doing scanning before and after treatment and seeing the drainage improve, and that will be proof positive. Do you have any thoughts about possible links between the theories and the factor the blood can affect cell metabolism, mitochondria? I've mentioned that before, right? And you mentioned in your July's video with Laurie Rivers, I don't know if any of you saw that Professor Peter Rowe had attended your conference. You invited him, and we agreed in virtually everything that Peter was doing. I agreed with it, and everything virtually we were doing, he agreed with. So yes. The main thing we have realized that the patients, a lot of them are stiff, and even ones with hypermobility in the neck and the lumbar spine, and most ME patients do have that, especially if they have Ehlers-Danlos hypermobility type, then they're going to have very hypermobile necks and hypermobile lumbar spines, but the mid-thoracics are often very stiff, even with that, and we did notice that. And also the flatness in the spine, Peter's seen that in many of his patients. Have you received any interest from practitioners running long COVID clinics? Yes. Well, I said that we're doing research with Salford Royal, who have a long COVID centre. Right, and we have a lovely question from Karen Nain. I don't know if Karen's there, but she's all the way from Delhi in India, which is probably about midnight there or something, or beyond midnight. So maybe she's not on with us. Mind you, Liv, it's middle of the night for you, isn't it?
It is, and Karen is here as well. So that's
Karen Nain. Oh, Karen Nain. Hi from everyone from Karen Nain. Hi, Karen. Can you say
Hi.
hello? You can unmute yourself. Karen?
Yeah. Hi, everyone.
Karan, hi. Karan, hi. Is it Karan? How do you pronounce it?
Karan.
Anyway, welcome. I'm sorry, my Urdu isn't up to scratch. I've not lectured in India yet, so I'll have to come over and lecture. But welcome from Delhi. So you say I've been suffering from post-COVID insomnia. Well, your insomnia is helping you stay up for this talk now, isn't it? I suppose you have good things about insomnia. No, for the last 8 months, I've been on sleeping medications, still not able to sleep. Even when I do, I don't feel fresh at all. Well, that's the thing. If you know my book, I talk about this. It's the neurolymphatic system was shown to exist during delta wave sleep. Delta wave sleep is the thing we need to stimulate. We need to stimulate delta wave. And therefore, when you wake up in the morning, you're unrefreshed because ME patients don't get delta wave sleep. This was proven in Stanford University. Karen, have you read my new book?
No, sir, not yet. Not the book. Yeah.
So the book has all about that there. But following COVID, one side of my neck was swollen from inside. You say you feel pressure around your eyes, pressure in your head, and you had swollen neck, and once inside and treated by medicine. Even today, after 8 months, there's slight swelling on the right side of the neck. Yeah, because it's not draining properly. This looks in line with what you described and what you've read online. Right, so basically, in the brain, we have the neurolymphatic system that since 2017 has been proven, and it's a drainage of the brain, but also drainage of the spine. So we know lying on your side will help some of that drainage, but it's during delta wave sleep that you get this drainage that should happen. But with ME patients, you're not getting delta wave, and delta wave is the restorative deep sleep. So we need to stimulate that delta wave. So how do we do it? Well, there are drugs that can stimulate delta wave. However, one of the drugs, sodium oxybate, which was used by some doctors in the research done quite a few years ago, showed it didn't help ME patients at all. So it stimulated the delta wave. So if my theory is right, it should help with restorative sleep, and therefore it should help the ME. So why didn't it work? Why did the study show no difference? And the reason is the drug sodium oxybate stimulates the sympathetic nervous system. So it's a side effect. So as it's helping the drainage of the brain, it's also overstimulating the brain with stimulating the sympathetics, which we do not want to do with ME. We want it to calm down. So it helps one side and the other side it's not helping. So that's why the drugs don't help. So how do we do it? Well, there are techniques. There are techniques to relax you off. And some of the best techniques are relaxation therapies like EMDR, or eye movement technique, which you don't need to use your eyes for it, like looking one way to the other. You can use tapping your fingers, and just put your hand on your thighs and just tap, alternating one finger and the other finger very slowly. When you're lying down in bed, just do this and concentrate just on those tapping fingers, nothing else. And that will help relax you off, and it should help you go into a deeper sleep. But it doesn't mean it's going to stimulate delta wave, but it'll help you switch off. But at the same time, there's a clever technique called CBT for insomnia, and it's not based on, it's loosely based on CBT, but it's not CBT for those who are really against CBT. It's designed for sleep, and it was originally shown to me by Professor Jason, I'll remember his surname in a minute. Anyway, Jason Leach, I think it was, but Professor Jason somebody or other from north of England, northeast. If anybody remember his name, I think I write it in my book. But anyway, so this professor in northeast of England is a professor of sleep medicine, and he has shown that by using these techniques, it really helps switch off the brain, and it can stimulate delta wave. Basically, you say to yourself, I'm not going to sleep. I'm not going to sleep. Not I am going to, I'm not going to sleep. So just keep on repeating that message. I'm not going to sleep. I'm not going to sleep. And at the same time, count from 1,000 backwards in sevens. And that's the difficult part. So you start with 1,000. Then you go to 993. Then 986. 979. It's difficult. You have to think. And that thinking process, which ME patients find very difficult, because a lot of them have brain fog, switches off the brain's thought process. And at the same time, I'm not going to sleep, I'm not going to sleep, and you'll drift off to a nice deep sleep. Now, if that doesn't work, there are other ways and means. And one of the best things I find is hypnosis. So you have to find, Karen, a good hypnotherapist to help sleep. I don't know, have you tried hypnotherapy in the past?
No, sir. I was advised. I know somebody who's very good at it, but I was a little scared, so I didn't do it.
Right. Well, hypnosis is nothing to be scared of. And what you should do is somebody who does a very gentle, passive Ericksonian hypnosis is what I use. I was trained in that many years ago. It's interesting because hypnosis people are scared of, and it's just a way of talking to your subconscious, and the subconscious is part of your whole limbic system that's been affected by in ME big time. So it's very important to switch that area off, and your subconscious, you can talk to your subconscious through hypnosis, and you can do a post-hypnotic suggestion saying, just by closing your eyes and counting to 10, you'll fall into a deeply relaxed state. And if you keep on practicing that, you will do it. Very, very useful. So that's my advice. From a supplementation point of view, some things like valerian root can help. Have you tried anything like that?
No, sir.
No, valerian. And also another thing that is really useful, that if are you allergic to anything?
No, sir.
No. If you had hay fever or anything like that, then you would probably have some antihistamines. And if you take antihistamine last thing at night, if you have an allergy, it can double up as helping things like hay fever, but also helping you to sleep. Take the drowsy one an hour before bed. But this shouldn't be continued for too long, but it can sometimes help. Okay, Matt, what are your thoughts of the possible benefits of the ketogenic diet for sufferers of ME? And Matt, we don't have a surname, but is Matt around? Yeah, anybody? No. Anyway, what are your thoughts on this? Matt, you're here?
Hello there, yeah.
Yeah, Fordy Ford, is that you?
That's the one, yeah.
Matt Ford, then, is it?
Yes, Matthew Ford, yes.
Right,
Like the
right.
car.
Okay, what are your thoughts of the possible benefits of the ketogenic diet? Yes, for sufferers. Well, I mentioned, did I mention, I did mention Anne McIntyre before, not Anne McIntyre, Sarah Manhart before, didn't I? Sarah is big on the keto paleo diet. Most of you have heard of Sarah Manhart, I'm sure. And there's been lots of studies done on ketogenics. Where are you from, Matt? Are you from this part of the
I live
world?
in Bristol.
Bristol, yeah. Have you heard of Sarah Manhart?
No, I haven't, no.
She's brought out books on the ketogenic diet. It does help some people, but some people it doesn't help at all, and some people it makes them worse. So it's really difficult because ketogenic diet, it does help the lymphatics, but your lymphatics are there to help fat metabolism as well. The lymphatic system in the bowels are different. They produce a chemical which is more white, known as chyle, and the lymphatics there are slightly different to the lymphatics of the rest of the body. So the lacteals, the lymphatic vessels of the bowels, help remove the fat, the excess fat. Now, if you have too much fat in your diet, it's going to overload the lymphatic system in your bowels, and that's not a good thing, because every lymphatic vessel, including the lacteals in the bowels, have sympathetic activity going on, and it overloads the sympathetics, it overloads the strain on the lymphatics, and the main thing with ME is that lymphatics are pushing the wrong way. So this is why you get leaky gut, and why you get malabsorption problems, and why you get gut dysbiosis, is because there are large molecules such as casein in milk, not the lactose, it's the casein, such as gluten, such as yeast, so sugars. Those are large molecules, the yeast, the gluten and the casein, and they are drained the wrong way. Instead of draining out through the lacteals in the gut, they're drained backwards into the gut, and this causes this fermentation of these larger molecules, and that's what we need the lymphatics for, and therefore you end up with gut fermentation, you end up with bowels going very bloated, you end up with pain, you end up with diarrhea, more constipation, and therefore you've got to be very careful about keto diet. It can make that much worse. So I would say if you're going to try it, but with a caveat that if you feel much worse, don't continue thinking it's going to be the answer, because it won't. But some patients do respond very well with keto, and some
Can I just say, before I went on keto, it was when I was eating food, my symptoms would happen after I had finished a meal.
Yeah.
And when I went on keto, the first time I went into ketosis, I felt my head drain, like physically, it felt like a cooling sensation, like it deflated. And it happened across all my shoulders and even in my hands. And instantly I had like way more energy. Brain fog disappeared. I could walk to the shops.
Yeah, it's wonderful. And I heard the story again and again. So for you, keto worked.
Yeah, I mean, big time. I'm still on it now, like years later.
But there's loads of patients like you. But there's a load of patients I've seen who tried keto and it's made them much, much worse. So
Yeah,
every patient's different. There's not one. And that's the trouble. And I have the utmost respect for Sarah Miles, Dr. Sarah Miles. She's an environmental specialist, a GP, and she was involved in environmental medicine for many years. She's had lots of battles with establishment over her work with ME, which has helped a lot of people with her diet. But she's very dogmatic in the keto, and she feels that everybody should be on it. And
I find that a lot with people in nutrition, and whereas it's my opinion, and I assume it's yours too, that nutrition is very personal to everyone's body, and there's no one right diet.
Absolutely.
So if you can do keto, fair enough. If you can do vegan, fair enough.
But with the keto, you're avoiding avoiding the sugars. You're avoiding the glucose. You're avoiding the yeast increase, and that could be alone. When you reduce yeast, you could be helping your symptoms as well. So it's a matter of avoidance of certainly. But when I say avoid, I don't say total avoidance unless you're allergic. If you've got celiacs and you're allergic to gluten, then you have to avoid it totally. ME patients are sensitive to it. Too much is no good. But I always say have a little bit every so often, cheat occasionally, and then you'll still produce the enzymes that can break down the different products. So reduce milk, reduce gluten, reduce sugars, reduce yeast. This is the golden rule with ME. Reduce. Stopping is all a matter of different patients, and going on different specific diets, it depends on different patients. So some people find the paleo diet, the Stone Age diet, good enough. Some people find the keto paleo diet. Some people just find the keto. So everybody's different, and you're right there, absolutely right, Matt. So I agree totally with that, and that's what I say. But you know, I have so many patients I help without them going on special diets, so I know that it's not absolute that they need to do a specific diet. But some patients do respond very well. I mean, I've reduced sugar over the last few months because I've been on this diet to make me healthier. So if some of you haven't seen me for some time, you might notice I'm a bit thinner. I've lost 2.5 stone, and that was just reducing sugars, reducing the bad foods, reducing fatty foods, and fried foods a lot, and doing more and just eating less, and you know, I feel much better. Anyway. Right, and we've got somebody from Alberta, just near Calgary. This is Wendy. Is Wendy there? Don't know if Wendy's on, but it's really nice. You know, I went out to see a patient. She won't mind me mentioning because I've mentioned to her in my book, Tatiana. And Tatiana is one of the people I've dedicated my new book to, the very severe patients I've seen, some of them anyway, who I've seen, who have been bedridden for years. And Tatiana was one of them in Calgary. And I went over to see her and to train up a practitioner to treat her. And she was bedridden. She used to be a circus performer. And Tatiana emailed me just last week with a picture of her, and she was getting married. She got married on Saturday, and she said she wishes I was there for her wedding. And when I saw her, the only time I saw her was when I went out over to Calgary. She was completely bedridden. She couldn't stand up, walk, or anything. And she was in a really bad way. And now she said she's walking down the aisle, and she's so thankful for the treatment. So that's what keeps me going. That's what's kept me going for 32 years doing this, or 32 years doing this treatment. So that's why we have a Perrin technique practitioner in Calgary. So I'm so thankful to be able to access treatment from a Perrin practitioner in Calgary, and hope that you will return in the future to train more across Canada. So do I hope. I'm a PT myself. Oh, right, physical therapist, that's right. Off work for a year now, but hope to recover and return to my profession, perhaps adding myself to the roster of Perrin technique practitioners. There will definitely be an ongoing unmet need, especially now with COVID long haulers. I have a few questions, but your time is limited, so please feel free to be selective in which ones you choose to address. Thanks so much. Looking forward to meeting and hopefully to attend your although the 8-hour time difference may prove a barrier, in which case I'll watch the recording. So yeah, so it's 8 hours behind here. So it's now, well, in the morning in Calgary, you know, ME patients don't do well in first things in the morning. I know, this is why we're doing this afternoon. I wonder if severe unresponsive to Perrin technique cases may benefit from investigation into idiopathic intracranial hypertension. Yes, well, we see this again and again and again, and there's a whole section of it in my new book. So yes, there were a group of doctors in Cambridge in the UK who said ME patients they've seen evidence that the problem is a buildup of pressure in the head, intracranial hypertension, increase in pressure within the brain itself. Now, this pressure buildup, you feel, a lot of ME patients feel it behind their eyes, behind their nose, and they feel this pressure, and some of them have severe headaches, but they don't get the telltale sign of intracranial pressure increase, which is they don't often get photophobia, they don't get papilledema, and the papilledema, some do, bright light does affect them, but the papilledema is a big thing, is when there's actually swelling in the back of the eye, and that happens when there's real increase in. So somebody looks through the eye, you know, the opticians and doctors will look through ophthalmoscope and see the back of the eye, and they can usually see if there's a edematous change, and this is called papilledema. So they don't have that, but they have headaches. They might feel nauseous. They don't have, but there's severe signs. And unfortunately, my family know all about that, because my son Max had a brain tumor, and he had severe increase in intracranial pressure. He had papilledema, which was missed by the optician, which was really serious miss. And he had severe headaches, and he had this projectile vomiting. So the very severe cases will have severe headaches, projectile vomiting, papilledema. Those are the most common presentations of severe intracranial pressure increase. And this is what gets recorded for people who have intracranial. But the doctors in Cambridge said, well, wait a second, what about all the minor cases? What about the people who have intracranial pressure, but it's only a minor case? They might not have the papilledema, they might not have the projectile vomiting, but they will still have headaches and pressure feeling. And these could be the ME patients. So maybe ME is a result of an increase in pressure. Now, if you were saying that the neurolymphatics are not working, just working the wrong way, there will be an increase in pressure within the head, a very small amount. And this could result in a lot of the symptoms that you see with ME. So it's a result of, so you'd expect this to occur if the neurolymphatics don't work properly. And this is what they're finding, that they did some lumbar punctures and drained off some of the cerebrospinal fluid in the brain, in the spine, and that reduced the pressure within the head, and it helped some of the symptoms. But I'm not advising patients to have a lumbar puncture, because it's a very drastic action, and that alone, that lumbar puncture itself, can trigger inflammatory changes within the spinal cord, and that could make ME so much worse. So I wouldn't advise this as a treatment. I'll say as a last resort, maybe in the future this might be used. But their argument was very simple. In every illness, say asthma, you see minor cases of asthma all the time in millions and millions of people, maybe even billions. So the most common finding is usually the minor cases, and the least common finding is the most severe cases. And this was different with intracranial hypertension. In intracranial hypertension, most of the cases reported were the severe cases, the ones with papilledema, the ones with increased pressure in the head, but they had papilledema, they had the projectile vomiting, and they also had these severe headaches. So these were the severe cases, and the minor cases weren't reported at all. So they're trying to redress the balance by saying maybe the minor cases are all the cases of ME. And this is a hypothesis, but when it's been talked about by other people. So yeah, it does possibly link to what we're saying. And another question, do you think that gentle rebounding trampoline workout may be useful? No, no, no. Right, it's useful when the person's better. When the person's well and is improving and doing really well, then maybe rebounding will help. But you've got to get the reversal of lymph working. Rebounder works on stimulating the lymph. It's the same as pumping techniques we have for the lymphatics that I teach in I do a course, undergraduate and postgraduate courses on lymphatic treatment for osteopaths and physios. And there's different techniques. There's the Miller pump technique, which is on the chest. There's the abdominal pump technique. There's a Dalrymple pump technique on the feet. There's different pump techniques which pump the lymph working. These are totally wrong for ME, because ME and fibromyalgia, it's not that the lymph is not working. It's not the sluggish lymph. It's the reversal of lymph. It's going the wrong way. So therefore, gentle rebounding will stimulate the lymph to work more in the wrong way. It's rebounding is good for lymphatics, but if your lymphatics are working wrongly, you'll actually stimulate it to work the wrong way. And therefore, it would actually cause more drainage problems and more build-up of toxins. So definitely no gentle rebounding in the early stages. When the person's recovered and doing really well and getting better and better and started to do a bit of graded activity paced activity to improve the stamina, then maybe rebounding will help. Yes. Okay. Now, Jared Younger has been working for fatigue study. I mentioned Jared Younger's work before, and Jared is in touch with me. And hopefully, if I can get him for next year's online conference for practitioners, we're going to get him. But he said he's really excited about what's going on with my work. And yeah, so Jared Younger is a neuroscientist, who's a professor at Alabama University, and he believes it's all about neuroinflammation, which is definitely. And finally, I'm wondering if adding more sacral or even visceral techniques might also be of benefit. Well, Peter Rowe in New York, in Johns Hopkins University, he uses a technique. The osteopathic physician there, who's a physiotherapy professor, does osteopathic work, does a lot of visceral work as well as cranial work. Visceral, because in France, they're very into what's known as visceral work, which is working on the fascia around the organs. A lot of times it's working the fascia, and the fascia is very much the tissue which has a lot of lymphatics travel in the fascia, the deep fascia and the superficial fascia, and the deeper fascia around the viscera, around the organs. And there are techniques to stimulate this. And there's a liver quiver, there's different things. We work on the spleen sometimes. Yeah, there are visceral work that will definitely help with the process, but it's a specific. In France, they're very big because of an osteopathic physician there called Barral, and he teaches a lot of visceral techniques. He's the master of visceral techniques in the world, and obviously in Canada, with their roots in French osteopathic philosophy, do a lot of work on Barral. So they use visceral techniques, yeah, and they can do that as well, yeah. So practitioners need to do the Perrin technique, but they can spread out and do other things as well. I'm not stopping them doing that. One thing for sure, they shouldn't just do their techniques without my techniques and say this is the Perrin technique. So the Perrin technique is actually quantified. In the new book, I actually go through stage by stage what the practitioners should do, much more than the first book. And therefore, if you practitioner isn't doing the things that I say in my book at all, or looks completely different, stop and question them if they're doing the Perrin technique, because if you're going for the Perrin technique and you're having something completely different, then it's no good. Do you think that some patients there may be other restrictions around the sacral cord affecting CSF flow or fascial restrictions? Well, sacrum is when we do craniosacral therapy, we stimulate the head, but we also stimulate the sacrum as well. The practitioners should have some of the treatment should be on the sacrum, maybe not the first time, but within the whole treatment process. The sacrum is important because the fluid goes down the spine and round the sacrum and up again. So the cerebrospinal fluid, which drains into the lymph, this is the neurolymphatic pathway. We need to stimulate that. So yeah, so sacral work is very important, especially when you've got parasympathetic nervous system problems. This very top, the suboccipital area of the top of the neck and the sacral area, very important for parasympathetic activity. And some patients, it's not just the sympathetic nerves that's going wrong, it's the parasympathetic, and then there's the vagus nerve. And so the sacrum is very important. The suboccipital area is very important for getting the parasympathetic nervous system working better. So that's for more people in the know. Then we've got a question from Pip. My Pip, is Pip around? Pip, yes, I can see Pip. Hello, Pip. You want to unmute? Don't know where Pip's coming from. I can see you on the board. Don't know if you can hear me. Hello, Pip. She might be in a different part of the world and she's pipped off. No. Pip, hello. Hi. I can't unmute. Oh dear. Never mind. Anyway, she's hello from Pip to everyone. Okay. Anyway, Pip, my bloods show very low TSH. Ah, right. So she's talking about the thyroid, the thyroid stimulating hormone, and T4 and T3 as well. However, I have many signs and symptoms of hypothyroidism. So TSH, if it's very low, it means hyperthyroid. I'll explain all this in a minute. Additionally, a previous more comprehensive test showed low T4, T3. The set of circumstances could mean secondary or tertiary hypothyroidism. Right, okay. We're working to go into much more, but the thyroid is important. The adrenals are important. Some of you might know Barry Wakefield, help me out here, thyroid. Barry Peatfield, that's it. Barry Peatfield. So Barry Peatfield is a doctor who defrocked himself before he got chucked off the General Medical Council, because he, like Sarah Mile, went out of the box, went out of the nice guidance for ME, and he started looking at hormones. Unfortunately, another doctor who I was very friendly with, Andy Wright, did the same, and he got struck off as well because he went out the box. And Sarah Mile got suspended for 6 months. Doctors who go out of the nice guidance, or the old nice guidance for ME, always got in trouble with the GMC, and Barry Peatfield was one of them. So he took himself out, and he writes books, and I think he sees patients, but his whole opinion is that ME is a problem of the adrenal glands and also the thyroid gland. It's hormonal. Now, I work very close with a whole team of endocrinologists, because at Salford Royal, the team who run the ME units are endocrinologists. So Adrian Heald, Dr. Adrian Heald is a consultant endocrinologist, is also a consultant psychiatrist, and also a consultant physician, but he runs the ME unit. And there used to be Anis Mukherjee, and Dr. Anis Mukherjee, she's written a book about menopause. She's in Manchester Spire Hospital, if you want to look her up on the web, Dr. Anis Mukherjee. And Dr. Mukherjee and I have been working for many years, and I send a lot of patients privately to her, and she does a lot of tests on thyroid and tests on adrenals. But it's the hypothalamus that controls the pituitary gland, which controls the adrenals and controls the thyroid. We always hear about the HPA axis, the hypothalamic pituitary adrenal axis, causing a lot of these problems, but it's also in the brain, in the nervous system, in the brain. You've got the adrenals, you've also got the noradrenals, so noradrenaline or norepinephrine in the brain. But all the hormones are controlled by hypothalamus, which is controlling hormones by a feedback mechanism. So hormones enter the brain, and the brain is measured, and then the hypothalamus measures them and sends messages back. And this is no exception with T4 and T3. T4 is thyroxine, T3 is prethyroxine, and it's the iodine part of the thyroxine, of the thyroid hormone. And T3 is very important for bone metabolism. T4 is very important for metabolism. And if your thyroid is not working properly, if it's low, you might put on weight. If you're hypothyroidism, if you're hyperthyroidism, you can be like high adrenaline all the time. And sometimes there's a goiter, there's a swelling of the thyroid gland in your neck. Sometimes there isn't. But end of the day, it's not usually the thyroid problem. Most ME patients will have slightly higher or slightly lower than normal. And that's because the control mechanism, the hypothalamus, is going wrong because it's being poisoned. So we get the hypothalamus working properly, and then your thyroid levels will change. So I say to people, if they're on thyroxine because they've got hypothyroidism and their T4 levels low, and they're on thyroxine as a supplement, as a treatment, check their thyroid levels every so often with the treatment, because with the treatment, the hypothalamus will start working better, and then your thyroid gland via the pituitary gland will start working better. And that's the thing. This TSH is a thyroid stimulating hormone produced by the pituitary, again by action from the hypothalamus. So that could be what's going on. It's a dysfunction of the hypothalamus, and this is absolutely clear what's happening with you. So this is why what the Perrin technique does, it drains off the toxins affecting the hypothalamus. Your hypothalamus starts working better. That makes your pituitary gland start working better, which makes your thyroid and your adrenals and all the other hormones working better. Okay. Julia Smith, I think it's the last question on the right, and we have a few more minutes if we want to open it up. Julia Smith, since starting treatment, my symptoms have improved, especially debilitating brain fog. I'm at session 20, so it was probably quite severe, and continue with a weekly appointment, so probably very severe, with a registered practitioner, because I do not manage to do all the 3 of the self-treatments at home every day. You don't need to do 3 self-treatments. The turning ones, yes. The nasal, the whole full massage once at night before bed, not 3 times a day. If you're doing the nose and the head, you don't have to do that, but you can do it. So don't have to. Nonetheless, I'm improving. My main question is, when people have improved, do we ideally continue 3 times self-treatments? No, you don't do it. You shouldn't be doing it at all. If you have been doing it, you've been pushing it to the limit, and it might have helped you, but God, it might have made you much worse to begin with. What is long-term protocol? So I've explained. I've received conflicting advice about where to do position of hot and cold packs. My practitioner suggests horizontally across the lower neck, upper shoulders. No. But some patients I've spoken to say the practitioner advises vertically down the spine. Down the spine is the right way. Down the spine, cold and warm. Cold, not freezing. Cool as you can have without it freezing, and warm, not boiling. That's important. But if you have fibromyalgia, if you've got a lot of pain, widespread pain in the whole body, and it's fibromyalgia, you should put cold only on your spine and warm on the muscles. If you're still doing it after 20 weeks, I'd just go to cold only and leave it, just down the spine, not across. If you find warmth helps around your muscles, you can put warmth on there, but not on your spine. Just cool on the spine, warm on the muscles, or if you prefer, if you like the hot and cold, carry on doing that. Hot and cold should be started 3 times a day. As you get better and better, you can do it once a day eventually, maybe when you're symptom-free, maybe just once a week. But you don't need to do just, often I change to the cold only, and it's not hot and cold, it's warm and cold. Okay, so hopefully, and it is vertically down, so not cross. So whoever told you that, not exactly right. Okay, so we've finished the questions that were sent in to me. So if you have any other questions, you can, I think you can raise your hand. Can you do that? Should be able to raise your hands. We've got 28 people still enrolled. Louise's phone. Louise, right. So Louise has raised a hand. So can Louise please unmute and just tell me where you are, who you are, and where you're from, and then give me a question. So hello, Louise.
Hi, I was diagnosed coming up 4 years. I'm from the northeast of England, and at the moment
I can tell the accent.
Yeah.
Okay, so I spent a year in Sunderland. Which part of the northeast are you from?
Well, I've just moved from Hartlepool to South Shields, so nearer to Newcastle now.
It's beautiful. Yeah, so I love it. We've been on holiday a couple of times up Northumbria coast, lovely coast. I recommend it to anybody. Anyway, so Louise, what's your question?
So I was trained originally by Liz, and who was based in Durham, but obviously she's retired now. At the
she's
moment,
moved
I'm
down
travelling
south.
2 hours.
I know. We need new practitioners. This is what you lot can do. You really can do it. You're a big group, and you can get in touch with local practitioners, maybe as a group or whatever, and find other people in the same area and say to the practitioner, listen, there's a whole group of us that want treatment in your area. Can you train up? And I'm starting training now, hands-on. I'm doing a course in London in a couple of months. Next month I'm doing, actually no, that's a lymphatic course. But there'll be trained practitioners going through every couple of months. We're doing some new training. And I'm trying to get as much practitioners as possible, as many as possible in the UK, trained up, because a lot of people want it. So that's what you need to do, Louise, is get in touch with somebody local and say, can you get in touch with them?
So there's nobody. There's nobody in the pipeline then.
No, unfortunately, the nearest to you is probably Edinburgh.
Yeah, I see Sylvain, and so we travel
so in
like
Yorkshire,
2 hours.
you have in Yorkshire, yeah, that's 2 hours that way. Yeah, you've got Sylvain is one of our practitioners that works in our clinic as well. She's brilliant.
Yeah.
There's also in Yorkshire we have Walter we have Stanley Purcell, who's in the middle of Yorkshire, so he's on the map. Stand Purcell, but that still might be too far for you. Okay, sorry about that. Sorry.
It's okay, thank you.
We do need your help
today as well.
Thank you. Has it been useful?
Yeah, it has. Yeah, thank you very much for your time.
My pleasure. Yeah. Any other question? Right, Hayley. Hayley.
Hi. Yes. Hi.
Hi, where are you from?
I'm from the Midlands in
Midlands, yeah. Hi.
Near Coventry. I was diagnosed with ME, oh God, well over 10 years ago now. I've been up and down like a yo-yo. I currently am seeing a practitioner who's just qualified. I think he's just in your course not long back. I'm one of his ones that he's treating.
Yeah.
I feel like it's going all right at the moment, but my issue is actually, and he knows this, I have multiple other conditions. So I have the GERD, the real severe. I also have pelvic congestion syndrome.
Right.
So doing some of the positions, or like you say, lying down, I find that really quite painful, and I'm really struggling with sleep because.
Right. Do you lie on your left side with it raised up on your left side?
I can lie down for so long, but then it does affect my esophagus, but it also affects my pelvis with the pelvic congestion. Right. I get really, really bad pain.
Right. Okay. So yeah. So it is difficult because do you have fibromyalgia as well as ME? Is it more? Is it the pain?
I know it's not everywhere. I haven't been diagnosed with fibromyalgia. Only ME, but I get.
Yeah, you need a really, really good mattress, a very soft mattress, and you need to have it raised up so your head is higher than the rest, and that will help. And you lie on your side in that position with a very soft, very, very soft mattress. Should be comfortable enough to lie on at night time.
Okay. They are. Sorry, I am actually at the hospital tomorrow for a pre-op. My Perrin practitioner. Sorry, I've got brain fog at the moment. You'll have to forgive me.
Sorry, yeah, it's my talk. There's a lot of that.
He's on the fence whether I should go for it or not. He was hoping to get me further along. I was hoping that obviously the technique would help me with my reflux condition.
Yeah. Well, if you're having surgery done.
Yeah, they've put me down for surgery because they've done loads and loads of tests on me. Yeah. And I've got a hiatus hernia, I've got an ulcer, but I've also
make sure with the anaesthetics, they don't give you anaesthetics that's going to speak to an anaesthetist. Any local anaesthetics they might give you before they give it as a pre-op local or during has to be non-adrenaline. That's important. Okay. And when they do general, again, it mustn't have adrenaline, and it must also be as a little toxicity. So to treat you like they would do surgery on some very severe patient with heart problems, there are other caveats about what medicine to use for surgery. We have something about that in my new book. But if you can't find it, you can get in touch with my clinic in Manchester, and Elaine, the practice manager, has something that we could send out to you. I'll try and make it available for people who have surgery. And we'll have it on online for what is recommended, and it's recommended by the American doctor Chuck Lapp. He's an expert in this field. He's one of the Charles Lapp, one of the doctors, one of the senior doctors in the ME world. Okay, so that's important to have the right anaesthetics. If you need surgery, you need surgery. You know, at the end of the day. Obviously, you know, it makes things worse, but we're there to pick up the pieces afterwards.
Well, bless him, he always has. I've had a couple of surgeries, so he's always helped me through them. But hopefully he's hoping to become specialised, I think, in your technique for our area, but he's just practicing on me first.
Right, yeah. Has he done the course then? Has he done?
I believe so, yes.
What's his name?
Andrew Hodgson.
Oh yeah. So yeah, hopefully you'll be able to help. Anyway, yeah. Okay. Well, good luck with that. Anne Drisk, been waiting there. Hello, Anne.
Hi. I was just wondering. I'm from Scotland.
Oh, good old Scott. Which part?
I'm in the part Fifeshire.
We've only got 3 practitioners in Scotland. We need more.
That's what I was just going to ask you. I know of 2, one in Edinburgh and one in Glasgow.
Yeah. So they're both really good. The one in Edinburgh, Rose Stewart Mentis, she's been practicing for years. Unfortunately, she's thinking of one day retiring. I said, we can't have you retire, you're too good. But so she's really, really good.
And there's one in Glasgow, Daniel Gerber.
Yeah, there's also there's 2. There's one in just outside Glasgow as well in that area. So we have got, but they're not always on the website. Just
Kilmarnock?
In Kilmarnock we have as well. Yeah.
I was just wondering if there will be more, you know, because it takes me 40 minutes to travel.
Again, as I said to the previous, in the northeast, we do need more practitioners all over. So if you can get in touch with local osteopaths who do cranial, or physios who do cranial, or chiropractors who do cranial, or craniosacral therapists who have been very experienced and been here for years, then they might be able to train up and they can come to a course.
I have been visiting a chiropractor in Fife that does craniotherapy.
Right, so they might be interested. Yeah.
And she has your book as well, so I can speak to her and see.
Yeah, it's not that expensive to train up. You know, it's I make it as cheap as possible. It's only costs £500 for a 2-day course, which is not a lot for a professional course and professional qualification. So it's good CPD for continuing professional development for all these practitioners. So yeah, the more people that demand, the more workshops I'll do. But
what I'd like to ask you is my main problem with this ME. I've had this for 25 years.
Yeah.
And I had a bad head accident, and I think it started from there.
Yeah. It's very common trigger, the head. But you'll find other things have gone wrong in your body before that, and the head accident might have been the final trigger.
Yeah, because I suffer from a lot of head pressure and dizziness and tinnitus. And
so the cranial will help there, but you need the lymphatic drainage as well, which is part of the whole cranial spectrum. I wrote a paper in 2007 that was published in the American Journal, and they put it front page, and it was showing that the cranial rhythm the craniorhythmic impulse is the neurolymphatic system. So I published that paper in a major international American journal, but it was cited in the main PubMed Medline, and this paper in 2007 was way ahead of its time because they published it as a theory of what the cranial rhythm before the neurolymphatic system was proven to exist. So it was good that they published my paper on it. But the cranial is part of the drainage system. So cranial techniques will help the drainage, but you need the lymphatics as well. You need to work on the chest and back as well. Yeah.
Yeah, so I've spoke to Daniel, and I'm going to make an appointment and go over to Glasgow and get some treatment.
Yeah. So if you see him every so often, that will help. But yeah, that'll be good. Okay, wonderful.
Okay. Thank you.
Right, we have we have Ford again. Matt, you were next online. So what can I do for you again?
Hello. I'd like to talk more about overdoing it and just give you a brief experience from my personal experience. So I was doing the Perrin self-massages for about a year on my own before I'd seen a practitioner because I couldn't afford it, unfortunately.
Yeah, I'm sorry. That's a big problem we have because, you know, it's hard in the private sector. Osteopathy is only private in this country. There are some osteopaths who do work in NHS. I've been trying for 25 years to get an NHS or more. I want to be able to have this treatment available for everybody. And we do make reductions in treatment costs, and there's one or two, obviously I can't do everybody, there's one or two pro bono patients I do treat, but we can't, you know, it's so difficult because, and this is what creates, so there's always there's a good press and there's bad press, and there's always people saying, oh, Perrin technique, waste of time, spent a year, didn't help me, spent a fortune. It's always the case, unfortunately, in private medicine. If you don't help somebody and they spend all the money, you know, we try our best, and all the practitioners try, and sometimes there's very complex cases and need other things as well. But if it doesn't help and the person's paid all that money, they're going to really, really be against the treatment. And this is a big problem we have. And I do sympathize with everybody having to pay for anything for the treatment. If we don't want anybody to become poor and not get better with the treatment, obviously we don't want them to give all their money away to us.
Yeah,
so
I will say my GP has, a couple of them have been quite interested in the Perrin technique and have asked me personally about it, especially with links to long COVID. They seem to be a lot more interest from
I wrote a paper last year which was published and cited in over 100 journals now, called Into the Looking Glass Post COVID-19, where we said we know what's going on with ME. We know it's very similar post-COVID, and patients are going to develop. There's going to be millions of people around the world developing post-COVID syndrome, which is now called long COVID. So we predicted that last year. I wrote this paper in February last year, and it was published in June. And then online, it went online in June, and then published in paper, and I think a few months later. So that's why a lot of people are quoting my paper, because they said the scientists knew this was going to happen. It's happening. So it's been I shouldn't say a blessing in disguise. It's not a blessing, long COVID, but it's definitely helped push my work forward, and people are interested. Yeah, so that's why your doctors are interested. Yeah. Sorry, going back to your question.
Yeah, sorry, the original question was on overdoing it. So I had done the Perrin technique. I read your first book and did it for a year, 3 times a day. But then I started to do it more because I felt I could, and it feels good. It can get rid of some of my migraine symptoms at times. Yeah. So I started doing it 5-6 times a day.
You were having no treatment at the time, just yourself?
Just my self-treatment, yeah.
Yeah.
And I was doing it fairly firm. And then after about, I'd say, a couple of weeks to a month, I got some really bad symptoms I'm still now getting over. where all my migraines came back. My neck glands swelled up, it swelled up at the back of my neck. I couldn't turn my head properly. No energy. I really couldn't do a lot of the basic stuff I could before. And then I stopped it for a month, started to feel better, then did it once, and then all the symptoms came back again.
Did you do the head balancing, or we call it's called active headrest with a book behind your head?
No.
See, that's a do-it-yourself cranial technique that is mentioned in my new book. Doing the massage by itself will drain off some of the toxins, but it won't stimulate the cranial rhythm to work better.
I've been doing tapping the fourth ventricle. Is that?
Yeah, how did you do that?
So I get my two fingers together and then put it behind my occipital bone, making sure my posture is straight.
Who taught you that technique?
I was just looking it up because I read your book said about the fourth ventricle, something. So I started reading up about what it is.
Compression of the CV4, yeah.
That's right.
Well, see, the cranial rhythm, the compression, we now know. This Professor Mike Van Alzaker from Harvard, who I'm now in contact with, who hopefully will be lecturing at my next conference. He works next to the lab of the lab which actually have done. Professor Phelps in Harvard has proven why the drainage works in delta wave. And the question was, the drainage of the lymph of the cerebrospinal fluid out of the brain, if it actually occurs, you need a pressure to build up, and that pressure build up comes from somewhere. Now, what happens is that Phelps discovered in Harvard discovered that there's a blood flow rush out during delta wave, which causes a suction effect of cerebrospinal fluid into the ventricles of the brain, which creates a pressure in the ventricles, including the fourth ventricle. And this increase in pressure is what pushes out during delta wave the drainage. Now, Phelps discovered this, and I've mentioned it in my book, and it's really an integral part of why the treatment works. But it's what cranial osteopathic techniques are all about. It's what the cranial osteopaths call the CV4, the compression of the fourth ventricle. It's not just the fourth, it's the whole ventricular system. So Phelps, who's not an osteopath, who's a neuroscientist, has discovered the proof of why cranial works, which is what all based on my work. So that's really exciting stuff, and that's what you need as part of your self-treatment. So doing your own technique for that, it might have helped a bit, but it's got to be done in the right way, and you might have overloaded yourself, and then that's why you felt much worse, or it might have, by mistake, you might have done something to actually clog up the cranial rhythm when you did it yourself. So it's got to be very careful. The technique we use is a book behind your head, active headrest, and if you get a book that's comfortable and you just do it for about 5-10 minutes at night, it can help the drainage as long as it's comfortable. It's got to be comfortable because that will govern the function, but it's not as good as getting a cranial osteopath, but it's going to help in some way. But eventually you do need a proper treatment rather than do it all yourself. A lot of times patients have been helped by self-treatment, and it can help, and without a practitioner nearby, or if one can't afford it. But having a practitioner there to guide you is so important. So even once every so often to go to a practitioner. And I've done this with patients. I've had a whole family from Orkney Islands that came to me, and they came to me once every few months, and the rest of the time they did it themselves, but they needed that guidance. Okay, right. We're going to finish. It's 10:05 now. There's 2 more questions. One of the things, obviously, there's a lot of interest there, and we can go on all day, but I have to sort of two-door pip now. So I'll just answer. There's Bushra and Andriska. I've got 2 more. Bushra, if you can come on line.
Hi, Dr. Perrin.
Hello. Where are you phoning from or calling from or zooming
It's,
from?
I see you. I've seen you a couple of times and a
Bushra.
couple of weeks ago,
Right, you
yeah.
have. Right, you have. Hello.
Yeah.
Sorry.
Hi, I hope you're well. So, just since chatting to you, I've been reading up about the things that you've advised me
Yeah.
and trying to go with it. And I just have a couple of questions around that,
Okay.
about hypermobility.
Yeah.
And so I wanted to ask
Right,
two
yeah,
questions.
I do remember you now. Sorry. I was seeing which patients. Sorry.
Yeah, the
Yeah,
CCI patient.
yeah.
And so I just wanted to ask, like, because you know my case, do you think a virus could cause the onset of CCI? And
Right. Yeah.
and if you have hypermobility, does that mean you would have EDS?
Right. There is an infection. There's a very rare condition which is called Grissel's syndrome. I don't know if you've heard of that. Grissel's
I think
syndrome.
I've read it.
It's a very rare syndrome that happens after a throat infection or upper respiratory tract infection for young children. They get severe torticollis, so they have the infection, and then a few weeks later their head's like that and they can't stabilize their head, and they found that there's actually a dislocation of the ligaments in the upper cervical spine. This is called Grissel's syndrome, and there's a possible link between infection and the hypermobility of ligaments, which would fit into what we're seeing with some ME patients, but it's more likely to be with EDS. EDS, we know, and Ehlers-Danlos syndrome, genetic predisposition for EDS has got this link to predisposition for ME, and when the joints become hypermobile, if the upper cervicals are hypermobile, it can affect not just the drainage in the spine, but also your vagus nerve as well, as it comes out from the top. So what comes first, the chicken and egg? It's more likely that the hypermobility comes before the ME, and it's just a predisposition, but it can be the other way around. So yeah, it can be both. So there's more research needs to be done on that, but there's definitely a link between the two. Yeah.
So how would one get diagnosed for EDS? Because I'm very new to this.
Right, there is a genetic test for it. You have to have, if you have hypermobility in the rest of the family. Did you have any other patients, people in your family with hypermobility at all?
Not that I know of.
No.
Yeah.
So it's unlikely to be hereditary, genetic, and therefore it's unlikely to be EDS. But you can have hypermobility from, I said, it's been known, you could have started with it when you were a child. If you had an infection when you were a young girl, it could have led to some hypermobility, not dislocation, not Grissel's syndrome, or Grissel's syndrome, it's named after his French, but it could have been enough to cause hypermobility, enough that led to a problem later on in life. Yeah.
Okay, that's very helpful.
It's very difficult to actually have it diagnosed, but EDS, if they suspect it, they can do genetic tests. I think there's 17 different subtypes of EDS, so you can have it. Yeah. Okay. Right. Okay. We have. I think that's it at the moment. Olivia, did we want to do anything more before we shut shop? Because there's still, how many people are still online? There's still a lot of people. Still on. Olivia?
Hello.
Are you still there? Oh my God, what time is it there now? 1:15 what?
2:10 in the morning.
God, you need to go to bed. Did you want me to run through anything else? The self-massage routine, I think we've mentioned it. It's all in the book anyway.
Yeah.
I think people just need to get the new books to answer a lot of their questions. And
the patient handbook is more concise. That might be easier.
Yeah, so that has all the things that they need to do, and that's this smaller book here, and it's only see the size. You can see the difference. That's the big book, and that's the smaller book, much smaller. Okay, so anyway, hopefully this has been really useful. We'll do another one of these in the future. Sorry it's taken so long to get to you, but good luck with all your treatments and all your advocacy. And thank you for Olivia for organising this today. If you have any, Liv, have you got your has everybody got your email if they need to contact you?
It was posted in Perrin Points a few days ago, but I can share it again.
So Liv is the person to contact for any sort of information. She's our information guru. If you need one of my practitioners, we're on the website, and I'm trying to train up people all the time. So the more demand, the more training I'll do, and that's my key now. I'm back in the land of the living with PPE, and we're doing hands-on training again. Okay, so all the best. Take care, and hopefully, I meant in the nicest way, but hopefully I won't see you soon, and hopefully you'll all recover in your own individual ways, and there'll be less of you and more of recovered patients. Okay, anyway, take care. God bless. Bye bye for now.